Dr. Tarhini also has the distinction of being one of the hardest workers in this field. I quote his data all the time, as my own though. So please come on up and join us.
Many thanks, Omid. I'm grateful to you, the Angeles Clinic, and AIM at Melanoma for this honor to be part of this meeting. So these are my disclosures. I did consulting for these companies and research grant support recently from these companies.
We can't really
Yes. Just talk about the disclosures, so I kept it down. So I'm going to start by recent data we presented about the incidence of melanoma, and this is just briefly that, as you can see, looking at the incidence between 2010 to 2014, it continues to creep up. And this is divided by all stages, so yellow and orange are stages 1 and 2, 3 is stage 3, and red is stage 4. This is unknown stage. But unfortunately, the incidence continues to go up, and this has to do with the risk factors, obviously the unprotected exposure to sun, excessive sun exposure, tanning bed exposure, and so on, and underscores the importance of working on prevention and awareness of the risk factors. Moving on to my, the core of my talk, it basically focuses on patients that we call high-risk surgically resected melanoma. These are patients that Dr. Asner mentioned are treated primarily by surgery, but continue to be at high risk that the cancer may come back after the surgery. And these include patients with a stage 2, where the cancer is deeply invading the skin, as you can see here, or it's ulcerated. We see microscopic ulceration on the top of the skin, or patients where the cancer starts on the skin but then spreads into lymph nodes. So these are deep stage 2 and advanced stage 3 melanoma still at high risk that the cancer may come back. Recent data has given us an idea or an updated data on the survival of those patients. What's the 10-year outlook in terms of survival of those patients? And if you look at those that I'm highlighting here, the stage 2B and 2C, you look at the 10-year survival rates to be about 82 to 75%. The stage 3 populations, the 10-year survival is about 88 to 24%, unfortunately, in the most advanced stage. So adjuvant therapy, meaning therapy that's given after the surgery, gives us an idea or gives us the opportunity to cure this disease and minimize the risk that the cancer may come back. As far as adjuvant therapy options, so post-operative options for patients with melanoma after surgery, the high-risk population, we have 5 options that are currently approved by the FDA. Another option which is under review but expected to be approved in a matter of a few months. The first 3 drugs here, so high-dose interferon, pegylated interferon, and ipilimumab, are less relevant these days. I'm going to mention them just briefly in terms of history and see how things evolved in the adjuvant setting. So I will focus my talk primarily on the last 3 options: nivolumab or Nivo, dabrafenib, trametinib, and pembrolizumab or Pembro. So the old treatment, high-dose interferon, this is a drug that was approved by the FDA in 1995, and we really have been using it since until the recent changes and the recent data in the past couple of years only. High-dose interferon was tested in 3 major studies, and the primary outcomes that we look at are what we call recurrence-free survival. How long are we living without the cancer coming back? And overall survival. Does this drug reduces the risk of death from melanoma? The 3 main studies that tested this drug have shown that it consistently improves recurrence-free survival, but there was mixed data in terms of overall survival. More recently, in 2011, a similar drug called pegylated interferon was also approved based on a study that showed that it can reduce the risk of recurrence-free survival, but no impact on overall survival in this study with this regimen. The difference between the 2 is that this is given for 1 year. The first month is given intravenously and then shots under the skin the rest of the year. This one is given weekly as a shot in the skin or under the skin for up to 5 years. The quality of life is a problem. Toxicity has been a problem with this regimen, so thankfully we have new options now. In 2015, the FDA approved a drug called ipilimumab, or IPI, that was actually, it worked very well in reducing the risk of the cancer coming back and improving the survival of patients with high-risk melanoma. But the problem is that it has been toxic, and I'll mention some of this data a little bit later. So as far as interferon studies, to put it all together, a lot of studies tested interferon. Actually, an analysis looked at 17 studies, about 10,500 patients, and overall we see that it reduces the risk of relapse by about 17%. It reduces the risk of death by about 9%. This is now old. We don't use it, or kind of rarely we use it these days. As far as ipilimumab, the other drug, as I said, it reduces the risk of relapse. You can see the difference in the curves here. This is the hazard ratio 0.76, meaning it reduces the risk of relapse by about 24%. And this is looking at the overall survival, reducing the risk of death. The hazard ratio 0.72, meaning reduces the risk of death by about 28%. The problem, as I said, it's toxicity. So here, this table divides toxicity by grade, and the worst grade is grade 4. And if you look at grade 3, 4, these are kind of serious toxicities. We see that about 45% of patients have serious toxicity related to the drug. And about 48% of patients basically have a toxicity that leads to discontinuation of the treatment. It's not tolerable anymore, that we have to stop it. And actually on the study, about 5 patients, 1.1% of the entire patient population died from toxicity related to the drug. So we obviously had an urgent need for better drugs and new options. And one thing that we kind of looked at recently is, because it's so toxic, do we have to give this high dose of 10 milligram per kilogram of this drug, ipilimumab, versus a lower dose that's actually approved for stage 4, higher risk patients, patients where the cancer is spread and works well. And what we recently kind of reported, this was almost a year ago, that there's no difference between the high dose and the lower dose, and basically we could possibly treat with a lower dose and still have the same outcome. The hazard ratio was 1, meaning there's no difference between the two. And this is the revolution that Dr. Omid mentioned about adjuvant therapy, and Dr. Asner mentioned, is with these 3 new options. So the first drug, called nivolumab, or Nivo, in this major study compared to the old ipilimumab 10 milligram per kilogram, was a positive study. This is the study presented back in September and leading to FDA approval. The next study was the targeted therapy with dabrafenib and trametinib, 2 pills that have also significantly reduced the risk of relapse, leading also to FDA approval. And most recently, only back in April at the American Association for Cancer Research meeting in Chicago, we've learned about pembrolizumab, this another drug similar to nivolumab, where the study was also positive. This agent is currently under review. So I'm going to focus a little bit, give you some data about these 3 major studies that have really changed in a major way the way we treat patients. They're more effective, less toxic than the options that we had in the past. I'm going to start with a targeted therapy option, dabrafenib and trametinib. What does targeted therapy mean in terms of treating patients with melanoma? Have their cancer cells that have a defect in a gene called BRAF. This defect or mutation results in a protein that is, again, acting as an engine that is firing all the time, basically out of control. And this led to the development of medications that can block the activity of this engine. And research has shown that if you block this protein, BRAF, and the protein right below it, MEK, they can actually work better, and they can better control the cancer and minimize the cancer coming back. And this led to major studies in stage 4, and that were eventually moved into this stage, stage 3. So this is the study called COMBI-AD that tested the dabrafenib plus trametinib versus placebo in patients with a stage 3 melanoma. Patients were randomized 1-to-1, either got the dabrafenib plus trametinib or matched placebo, and were treated for about 1 year, for up to 1 year. The results were actually significant, actually were exciting in terms of the activity that was seen with these agents. The hazard ratio was 0.47, meaning we have a major reduction in the risk of the cancer coming back or relapse-free survival. If you look at the 1-year data, this is the treated group, this is the placebo group, basically significant improvement between the two groups consistently. When they looked at overall survival, there is a very similar trend. These data are still preliminary here, and updates will continue to come, but basically there's a significant trend that actually it can also affect the mortality or reduce the risk that patients may die from melanoma. As far as toxicities, most toxicities are actually manageable, but they're there. There are challenges in taking any cancer medications. So if we look at any grade 3 and 4, the ones that we described as potentially serious, about 41% of patients may experience one of those. No fatal events at all were seen. And 26% of patients actually had to discontinue treatment, so probably did not make it for 1 year of treatment. And the classes of adverse events may be fever, pyrexia or fever, fatigue, nausea, headache, chills, diarrhea, vomiting, arthralgia, and rash. These are the common adverse events or side effects. Moving on to the immunotherapy, so the other drugs, nivolumab or pembrolizumab. How do these drugs work? If you look at this graphic here, so this is the cancer cell, and the T cell is basically, you can envision it as the soldier or the police trying to kill the cancer cell. And the way it works is that you have the control center. This is the programmer called the dendritic cell. It programs the T cell to recognize the cancer cell. So it programs it, and the T cell travels from the lymph nodes all the way to the tissue, let's say the lungs, the liver, etc., where the cancer cells are sitting, and tries to kill the cancer cell. If we zoom in here about what's happening between the programmer and the T cell, there is a lot of interactions that actually happen between the two that programs the T cell and activates it. Now the T cell is active, it knows this is cancer, and it's trying to kill the cancer cell. But our body has checks and balances. You do not want the immune system to be active all the time. If it's active all the time, it may lead to autoimmune diseases like lupus, rheumatoid arthritis, these kind of things. So our body normally has a checks and balances like this molecule here called CTLA4 that puts a brake on the T cell, puts a brake on the immune system to minimize this overactivation. But if this is a T cell that recognizes the cancer cell, we're now inhibiting the wrong cell. We want this cell to be active. And therefore, CTLA4 is not doing us a favor here by inhibiting the immune system. And this led to the development of drugs like the drug ipilimumab or IPI to block this interaction and allow the T cell to continue to be active and continue to basically recognize and kill the cancer cell. When we get to the periphery, to the tissue, let's say in the lungs where we have cancer cells, and the T cell now is trying to kill the cancer cell, if we try to zoom in here as well and see what's happening, basically this is the T cell trying to basically engage with the cancer cell and try to kill the cancer cell. Here, the cancer cell itself has some tricks. It can express certain proteins, or we call them antigens, that can engage with the T cell and inhibit the activity of the T cell. And they do this by engaging with another negative regulator, the PD-1 here. And this led to the development of drugs like nivolumab or Nivo or pembrolizumab, Pembro, that can block this interaction and allow the T cell to essentially do its job. So we'll move on to nivolumab, this anti-PD-1 antibody. that this is done in this study where patients with stage 3 and stage 4 melanoma were randomized to receive this drug, nivolumab, for up to 1 year versus the old drug, ipilimumab, at the dose of 10 milligram per kilogram, the Taussig drug, basically. And thankfully, the study was positive and was very positive. We saw that the nivolumab is superior to ipilimumab. It's more effective, and also, thankfully, it's much less toxic. And that's also, obviously an important thing. And this led to the FDA approval, as I mentioned. As far as adverse events, when you stop these checks and balances on the immune system, you're probably making these T cells work a little bit more. And this may lead to what we call autoimmune side effects. Things like inflammation of the bowel or diarrhea, inflammation of the liver, inflammation affecting our hormone glands like the thyroid and so on. Most of these are manageable with steroids, drugs that can cool down the immune system. As far as serious adverse events, these are seen only about 15% of patients. The next study, which was presented only in April, as I mentioned, is the study that evaluated the other drug, the anti-PD-1 drug, pembrolizumab. So pembro versus placebo in patients with stage 3. This study planned to treat patients for up to 2 years and allow the crossover. So patients who had placebo and progressed, they were given the opportunity to cross over and receive the experimental drug, or pembrolizumab in this case. This study was also thankfully positive. This is the hazard ratio, 0.57, so essentially about 43% reduction in the risk of the cancer coming back. And when we zoom in at different groups, let's say stage 3A, 3B, 3C, consistent activity, here hazard ratio 0.32, and here again, stage 3B and stage 3C. It's effective across the board in all these subgroups of stage 3 patients. As far as toxicities, it is very similar to the other drug, nivolumab. It's the same class of drugs. They work very similarly. So if we look at the treatment-related adverse events, so about 14.7% will get grade 3 to 5, meaning the serious adverse events. Unfortunately, there was one fatality on this study, a patient who had inflammation of the muscles and called myositis that eventually, it is rare, but it does happen with these medications. We'll move on to the next topic, which is the neoadjuvant therapy. So we talked about adjuvant therapy, meaning patients had surgery, now recovered from surgery, and we give them drugs to minimize the risk that the cancer may come back and hopefully improve their survival. Now, what about those patients who come in with bulky disease? So still stage 3, the cancer is spread into the lymph nodes, and they require major surgery. Is there benefit from doing the treatment before surgery? Maybe shrink the tumor, make the surgery a little bit easier. Does this help us with the surgery, or does this help us in improving survival of those patients by doing the treatment before surgery and not delaying it because of the surgery? So the advantages of neoadjuvant therapy is improving the clinical outcome. This has been shown in other cancers, like breast cancer, for example, where we improve survival. We may reduce the size of the tumor and allow us to do a less morbid surgery, for example. And from the research perspective, experimentally, we have the ability to access now tumor and blood before and after we give the medication, and allow us to investigate at the molecular level in the lab what is happening with these drugs, what drives resistance to these drugs. Can we come up with certain biomarkers or blood tests that can tell us what patients are more likely to benefit versus others, what patients are more likely to experience toxicity versus others? So this is kind of a major value of this neoadjuvant approach as well. Historically, there were 2 major studies that tested so-called biochemotherapy. These are all the studies combined chemotherapy with immunotherapy and showed promising data at the time. We can shrink the tumor in about 40 to 50% of patients. Importantly, this is so-called PCR, or pathologic complete response, meaning when we do the surgery and send the tumor to the pathologist, they cannot see cancer at all. So we basically eliminated the cancer at the time of the surgery. So this PCR was in about 6 to 11% of patients treated with this approach. It was a toxic approach, did not make it far at the time. And there were drugs like chemotherapy, so-called temozolomide. They don't work for stage 4. They were shown don't really work for stage 3, was also abandoned. Now, as far as immunotherapy, this is some of the studies that we've been involved in testing, like a drug called interferon alpha. Another drug, the ipilimumab at 10 milligram per kilogram. We tested ipilimumab at 10 or 3 milligram per kilogram plus high-dose interferon. So different approaches to better activate the immune system, or interferon plus pembrolizumab, the anti-PD-1 antibody. Overall, in terms of the PCR, which we think is the most important, let's say, marker of how well these drugs are working at the level of the tumor, we saw that about 15% of patients had a complete pathologic response, no cancer at the time of surgery, with this interferon alone. With ipilimumab at 10 milligram per kilogram, we had 0 PCR. So when we did surgery, when our surgeons did the surgery, basically we still found cancer in every patient. And when we combined interferon with ipilimumab, 32% of patients achieved a complete pathologic response, and pembrolizumab plus interferon, 35% of patients. Now, a lot of groups are investing in this approach. There are studies testing dabrafenib plus trametinib, and was a recent promising report published. There are studies with nivolumab plus ipilimumab and other drugs. So this is an active area, very promising, and hopefully eventually will change the care of the way we treat patients, if proven to be as effective as it was seen in breast cancer and other diseases, but hopefully better, we hope, because we have great immunotherapy and target therapy drugs these days. So one other value briefly, before I finish my talk, is this value of biomarkers that I mentioned. This is a high value of neoadjuvant studies, the access to the tumor and the blood before and after treatment. And when we look at some of the things we look at is predictive biomarkers. And as I said, these are biomarkers that can allow us to treat only those that are predicted to respond and save the others, for the toxicity and the cost of the treatment, and basically offer them other treatments that are more likely to work for them. And prognostic biomarkers can tell us what patients are at high risk of the cancer coming back versus those who are at low risk that the cancer may come back. And this is one of the studies, the 10 milligram per kilogram ipilimumab, where patients who had this stage 3 bulky disease did a baseline biopsy, treated them for 6 weeks, did the definitive surgery, and gave them a little bit more treatment after. So one of the studies we did is looked at the genes that are expressed within the tumor. And we focused primarily on what we call the immune-related genes, and saw what genes are turned on, what genes are turned off. So if you look at the genes of these patients in red here, green in this graph means that they were turned off. These are not active genes, these immune-related genes, genes related to the activation of the immune system. These are, so the red and black, these are hyperactivated. And in this area here, black and green, a little bit of red, these are in the middle. So those who had low activation of the genes basically had a very high risk that the cancer may come back. So these are the patients who relapsed quickly after the surgery. Those who had the high activation of the immune-related genes had a very low risk that the cancer may come back, and basically had more active immune system. So we looked at this as a potential biomarker that can differentiate patients, more likely to benefit versus not, and basically a major study is currently trying to validate these data and see if we can make it to the clinic with this test. Another test we did is looked at the risk of toxicity. What I mentioned is those drugs can, when they disinhibit the immune system, can make the immune system affect normal tissues like the bowel. So we have colitis and diarrhea. And one of the kind of interesting observation is a protein in the blood, or we call it a cytokine called IL-17, which was very high at baseline before any treatment in patients who ended up with this colitis. This is the bowel, and this is basically ulceration in the bowel of one of our patients who had colitis. So this was another potential biomarker that we're currently further investigating. And with this, I will conclude my talk, and thank you very much.